Thank you very much for your kind introduction, and thank you very much for giving me a chance to present our experience about retransplantation and then liver transplantation. And thank you very much, Professor Lee, for inviting me in this very beautiful country. I love it, and I always appreciate your help working together as one of the leading country in Asian liver transplantation. So, since we started the liver transplantation in 4 decades, the introduction of the liver transplantation and the cumulative result and the number of the transplant recipients had steadily grown in my country, as you can see in the slide on the left side. The case number reached 12,000 right now. And this demographic shift naturally brings a parallel increase in the cohort of long-term survivors, and many of whom now face late graft failure due to the chronic rejection and the recurrence disease or graft attrition. As a result, there is a rising possibility of the liver retransplantation becoming a more frequently clinically a necessity. As you can see in the slide on the right side, you can see the retransplantation case number annually in my hospital, in all my country. It accounts for 3.5% of the retransplantation rate in the total. And you can see in the slide on the left side, as you can see, and there is a little bit increase of the disease organ transplantation in my country. As already two former very nice presentation, as you can see in this slide, shows issues in the liver retransplantation in Japan. As you may know, more than 70% of the patients receive the retransplantation with a living donor in my countries. The liver transplantation poses substantial technical challenges that are significantly more complex than the primary liver transplantation, especially in the living donor-dominant countries. And because of the scarcity of the disease donor options, limited donor pool for the second living donation, and the ethical limitation, and the high expectations of the surgical precision and the safety, we can achieve nearly 60% of the long-term patient survival in the retransplantation setting. There's several points of when we perform the retransplantation in the case. The severe adhesion around the hepatic harvest and the inferior vena cava from previous surgeries make retransplantation and dissection difficult, and altered vascular and biliary anatomy should be necessary. When it comes to the hepatic artery, the problem is very common and challenging because of the thrombosis and sometimes dissection or limited residual length, often necessitating interposition vein graft. Since we use very frequently right gastroepiphyseal artery for the reconstruction for the hepatic artery at the time of the retransplantation. And the portal vein, as you can see in the slide on the right side, thrombosis of cavernous transformation may require thrombectomy, venoplasty, or even portal vein interposition using vein graft or clot loss. And a cable reconstruction may be complicated by fibrosis before, especially in a conventional piggyback technique. And the native bile duct are often unusable due to the plial anastomosis or complications, leading the need for the Roux-en-Y hepatic jejunostomy even in adult recipients. Then first, I'd like to show you the retransplantation for the patient with the portal vein thrombosis. As you can see already, you can see the bloody mesoablation. It's a portal vein is completely, the thrombosed. It's blood is coming from the collateral vessels. Then how we can expose the portal vein, and how can we make the portal vein anastomosis in this scenario. Then we expose splenic vein below the pancreas, just in circular splenic vein in here. And then this is an IMV. Then this is nearly the main trunk of the portal vein. Then dissection is direction to the upward behind the pancreas. Then we encircle the main portal vein. You can see the main portal vein is completely thrombosed. And then we pull out the portal vein behind the pancreas. And this is as you can see, this is an SMV, IMV, and a splenic vein. Then we take the vein graft from the external iliac graft. It's a very suitable size and the length you can take from the left external iliac veins. Then we can anastomose interpositional vein graft with the external iliac graft like this, with a sixo-pedius posterior interrupted, posterior continuous, and anterior interrupted. Already the patient condition is very bad, as you can see in this slide. There's many oozing happening during the portal vein reconstruction. And we pass the portal vein behind the pancreas, then make an osmosis with a graft portal vein like this. We use live donors as usual, and this is a left lobe graft, and the portal vein reconstruction has been made with a sixo-pedius posterior continuous anterior interrupted suture, as you can see in here. Then we complete the anastomosis and reperfuse the liver. So this is a very complicated case, but we can achieve the re-transplantation very safely. Okay. Then moving on the next slide. So re-transplantation is typically associated with the longer operating time, higher transfusion requirements, and the greater hemodynamic instability, especially during the vascular dissection or cross-clumping. So, veno-veno may play a role in controlling venous or portal pressures, or as you can see in the slide on the right side top, portal cable shunt, temporary portal cable shunt play a role to control the portal pressure and systemic pressure. And also, the former presenter told us that the machine perfusion pump will be effective, preventing a prolonged cold ischemic time. Not only the optimizing the graft quality, but it's not approved in my country yet. So we are trying to get approval from FDA. And the surgeons must be prepared for on-the-fly adjustment, including the unplanned conduit use or vascular shunt or total hepatic vascular exclusion. These operations require a high experienced multidisciplinary team, including the transplant anesthesiologist, interventional radiologist, and a critical care specialist. The next case is, as you can see in here, hepatic vein stenosis after liver transplantation. This is a pediatric case, and we put the stent on the left hepatic vein, and the patient is doing well, but after 10 years, we have to do the retransplantation for hepatic vein stenosis and the chronic rejection. So we put the stent on the left hepatic vein. Reverse T incision was made, and there is a dense adhesion, as you can see in here. Successfully clamped the portal vein. And then we can identify IVC from the right side. The bottom cable is very difficult to take, a sling, because there is many fibrous tissues around the hepatic veins. The landmark is the left renal vein. Just above the left renal vein, we make a sling in the bottom cable. So gently mobilizing the IVC, and finally we can make a sling on the bottom cable like this. Then we clamp the cable, top cable first, and the bottom cable next. And I cut the left hepatic vein with the stent. You can see the stent inside the lumen. We take out the stent and I cut again the left hepatic vein, but the stent is still stuck in the lumen. And the quality of the intima is very bad, as you can see in this slide. We cannot apply this hepatic vein or IVC or the reconstruction of the hepatic vein. So what can we do for this scenario? Then we clamp the IVC again, then try to make good anastomosis orifice, but it's still the quality of the intima is not so very good. So we close the top IVC because there is a long ischemic time and the bleeding a lot. Close with 5-0 proline with a continuous suture. Then what can we do for this patient? This is operation planning, very important. Then declamp the IVC, free from the total vascular exclusion. Then mobilizing the IVC from the diaphragmatic attachment. We just cut the right phrenic vein from the IVC. Then we can sling the top cable like this. As you can see, there is the dense adhesion, and this is a right phrenic vein. You have to tie it up and just elongate a little bit more to the top side of the IVC. Then you can see here is a pericardial fat tissue is exposed. Then we can see this is the pericardium cavity, so we open it. Then we can a little bit down the location of the healthy IVC to the abdominal side, as you can see in here. It's not necessary to expose all IVC, just pulling down the right atrium. Then we cut the IVC completely, rejecting the unhealthy parts. It's a very fibrotic tissue, so we have to anastomose the IVC again, only the posterior wall, to make a healthy orifice for the anastomosis. So this is anastomosis site, very healthy, and a sufficient orifice. You can see the 3 centimeter in the diameter, and we put the graft from the father in this time. Then anastomosis was made with the 5-0 proline with a posterior continuous anterior interrupted suture. So these kind of the complicated procedure, we have to learn a lot, and we need some expertise to accomplish this kind of complicated operation. So far, we've done nearly 1,000 pediatric liver transplantation in my hospital, and I personally have 2,000 pediatric liver transplantation experience in my whole life. So we need an experience and expertise hands to complete this kind of the complicated operation again. So then when the portal vein and the hepatic vein reconstruction is achieved, the liver perfused well. This is anastomosis. Actually, we didn't close this lumen because there is a pericardium cavity will be if you close it, there is some problem in the future. So this is my conclusion. I'd like to say that liver retransplantation represents one of the most technically demanding procedures in the HPV surgery, requiring expert surgical adjustments and meticulous planning and real-time adaptability. As the transplant recipient population matures, the demands for the retransplantation is expected to rise, underscoring the need for dedicated surgical expertise, institutional readiness, and ethically sound allocation policy should be necessary. Thank you for your attention.